Hi, Kara.
Hi, just getting myself set up here.
Sorry, I have my chair too low.
You have what, sorry?
My chair is too low. I have to set up my chair. I just realized that I didn't have my name.
You might want to turn off recording so it doesn't transcribe us until we want it to.
Okay, thank you very much, everybody. Let's get started. So, good morning or good afternoon, depending on your location. Welcome to our second week in New Frontiers in Health Policy Graduate Conference 2021. This is our Health Systems and Society oral session. So today we have three interesting presentations. First will be Joelle Deschatelet from Brock University, who will be presenting Exploring the Access and Use of Social Technologies by Long-Term Care Residents for Promoting Mental Health During the COVID-19 Pandemic, a Rapid Review. Second, we will have Jayati Qatar from McMaster University to present the influence of the social determinants of health on unmet needs, healthcare needs during the pandemic. And our third presenter would be Ahmed Bilal from McMaster University, who will present limitations of COVID-19 testing and case counts, why it matters for the policymakers. Today, we have the honor of having Dr. Hsien Seow as our discussant. Dr. Seow is a PhD from Johns Hopkins University, also BC from Yale. He's the Canada Research Chair in Palliative Care and Health Systems Innovation at McMaster University and Director of ISIS at McMaster site. Previously, he held the CIHR New Investigator Award and the Cancer Care Ontario Chair in Health Services Research. His website, www.palliativecareinnovation.com. He is the co-host of a very interesting podcast called Waiting Room Revolution. So thank you very much again for joining us. Today, we will start with Joelle. So thank you, Joelle. Please just a reminder for all attendants, sorry, that was my fault. To all assistants, please remember to keep your microphones muted, video off, and send us all your questions through the chat box so we can discuss them during the Q&A session. You can also click on your top left corner for order IA and get live transcriptions if you need that. So let's start. First, we have Joelle. Thank you, Joelle.
Thank you. So hello, everyone. My name is Joelle, and I'm a recent graduate of the Masters of Business Administration, Master of Public Health concurrent degree program at Brock University. And I will be presenting my rapid review paper on exploring the access and use of social technologies by long-term care residents in support of their mental health during the COVID-19 pandemic. Apologies. So here's a quick outline of my presentation. So I'll start with the background, methodology, study findings, key discussion points, and conclusion. COVID-19 disproportionately affects older people, where 80% of hospitalizations are adults over the age of 65. As a result, an effective measure of preventing the spread of COVID-19 is social distancing, which entails staying at home and limiting social contact. Unfortunately, increased social isolation that results from social distancing is associated with increased depression and suicidality, which is linked to pro-inflammatory and reduced antiviral immune responses. Social technologies are any technology that facilitates social interactions and is enabled by communications capability, such as the internet or mobile devices, and are used to mitigate these adverse outcomes. Studies report short-term benefits of social technology use in older adults, such as developing a positive attitude towards the usability and usefulness of technology, well-being and feeling of connectedness, and long-term benefits, including slow deterioration, improved physical health, and better management of chronic diseases. Currently, there's a lack of evidence concerning the benefits of social technologies and their impact on health, particularly in older adults. Therefore, this rapid review involves closing the knowledge gap surrounding the use and accessibility of social technologies by older adults and provide evidence to inform policy decisions in long-term care homes. The three study objectives are first to determine what are the outcomes and challenges related to the access and use of social technology by older adults in support of their mental health during the COVID-19 pandemic. Two, fill in the gaps in knowledge surrounding long-term care homes and the impacts of social technologies on residents' mental health. And three, to provide evidence to inform policy decisions on the implementation of social technologies in long-term care homes. So for my methods section, I utilized the following four databases for my search and gray literature, specifically Google Scholar. And although gray literature is not necessary for rapid reviews, I decided to include it due to the recency of COVID-19 and thus limited research that currently exists. My methods section included my eligibility criteria and highlighted the use of the PRISMA 2020 expanded checklist. Selecting references follows a standard process as displayed in this diagram. A total of 131 records were screened, where 111 records were identified through database searching, and 20 additional records were identified through Google Scholar. After removing duplicates, 114 studies remained. 33 were assessed for full text eligibility after inclusion and exclusion criteria were met, and this led to the inclusion of a total of 24 studies for the review. The studies were classified using a PICOS table, so population, intervention, comparator, outcome, and study design. Here is an excerpt of my PICOS table. The interventions included mainly information and communication technologies, so ICTs, hybrid solutions, including digital infrastructure and community support systems, telephone services, video communication, interviews, education on older adults of how to use ICTs and digital technologies, and video telehealth. There are many positive outcomes reported because of the implementation of the above interventions. These include improved mental and physical health and e-literacy, reduced health disparities, increased accessibility to electronic medical records on an online platform, increased autonomy, self-efficacy, social interaction, and life satisfaction. There are also negative outcomes. These include furthering the digital divide, feelings of exclusion and isolation when unable to access or use digital technologies, and it not being a feasible option for some. This is an excerpt of Table 3, Emerging Themes, Benefits, and Challenges. The results were thematically analyzed under 5 separate themes. These themes are 1, use of social technologies combined with community outreach, 2, use of remotely delivered interventions to improve older adults' well-being and mental health, 3, use of video conference compared to telephone only and telemedicine, 4, frustration and furthering the digital divide resulting from COVID-19, and 5, use of education on social technologies as a strategy to combat social exclusion and inequalities. Our findings from this rapid review shed light on the significant impact that social technologies have had on the mental health of older adults during COVID-19. Most studies reported positive findings where social technologies have improved older adults' mental health during COVID-19, and other positive themes emphasize social technologies' role in helping older adults stay connected with others. Out of each theme, the only one associated with a negative outcome is the one that indicates that social technologies may cause a further digital divide. The author rationalizes that social technologies presented a barrier for many older adults and created a sense of frustration when unable to function. However, accessing technology was a central factor in coping with COVID-19, maintaining social connections, and finding assistance for medical needs. A subgroup population discussed in some studies focused on long-term care residents. Elderly residents in long-term care homes are experiencing poor mental health outcomes due to isolation during the COVID-19 pandemic. These outcomes include, but are not limited to, depression, anxiety, low self-esteem, behavioral problems, and delirium. Digital health interventions and other digital technologies are used to mitigate these adverse outcomes by keeping residents connected to their family members and community, as well as engaged in activities that are meaningful to them. These technologies became very important tools to support residents and family connections since long-term care homes experience visitor restrictions as a means of keeping residents safe. Ensuring that long-term care residents have mental health support and access to social technologies is critical to their health and well-being. It is important to note that for approximately 3 months, the only method of communication between residents and family members was through virtual visits due to the visitor restrictions that were in effect in long-term care. There's an immediate need to foster social connections for this population through social technologies, including smartphones, robots, and tablets to enable communication. Staff support is required for most residents to utilize these social technologies. Recreation professionals in long-term care have led the way in supporting residents with social connections and have utilized technology in a variety of different ways in order to provide meaningful interactions and creative programming opportunities that otherwise would not have been possible. A special subset of long-term care residents live with cognitive impairment or dementia, which impacts their potential use of ICTs. Caregivers and staff should be present during video conferences to aid these residents and surmount this significant barrier. This rapid review enabled the rapid synthesis of a disparate evidence base during an ongoing pandemic to help policymakers in long-term care facilities be aware of the evidence available regarding social technologies and the associated benefits for older adults. The government, long-term care facilities, programs, and other relevant decision makers would benefit from understanding which social technologies have significant evidence in improving mental health outcomes. There are financial implications for health system administrators and planners for future investments in social technologies. This evidence will help determine whether increased spending on social technologies is cost-effective and substantially improves elders' well-being. More research is needed to assess the costs as well as cost effectiveness of social technologies in long-term care settings. Future studies should consider the costs associated with these social technologies and determine if the benefits outweigh the costs. This knowledge would help researchers generate evidence to be used by long-term care stakeholders to inform resource allocation and funding decisions. It could also guide future economic studies evaluating the cost effectiveness of social technology devices. The use of social technologies in improving older adults' mental health during COVID-19 has led to positive, negative, and neutral outcomes. Positive outcomes of using social technologies to improve the mental health of older adults include reduced loneliness, isolation, and health disparities, and increased autonomy, social interaction, life satisfaction, and digital inclusion. COVID-19 has furthered the digital divide for some older adults as they are frustrated and feel incapable of using or accessing social technologies to stay connected to their loved ones. In addition, staffing levels in long-term care facilities must be addressed so that residents can be provided with the level of care that they require and deserve on an ongoing basis. ICT is only one small, however, important area that could benefit from additional staff support, as residents living with long-term care deserve the opportunity to stay connected during the current COVID-19 pandemic and have opportunities to improve their quality of life moving forward. Thank you.
Thank you very much, Joelle. I would appreciate if you can stop sharing your screen so we can go to our second presenter, but very interesting. Thank you so much. So now I'm going to invite Jayati to please share her slides.
Yes, thank you.
Thank you very much. So again, if you have any questions, please share your questions on the chat box and we will go through them on the Q&A part of the session. Thank you.
Great. So, sorry, I'm just trying to sort out my slides. There we go. So, hello everyone. My name is Jayati Qatar. I'm a second-year Master of Public Health student at McMaster, and today I'll be presenting work that examines the experience of unmet healthcare needs during the COVID-19 pandemic, using data from the Canadian Longitudinal Study on Aging, a cohort of older adults. So we know that the rapid spread of COVID-19 and adoption of public health restrictions in Canada fundamentally affected access to healthcare services. To adapt to the additional strain of COVID-19 patients, healthcare systems were directed to cancel elective surgeries and in-person appointments, and we saw an increase on the reliance of virtual visits. National data has indicated that emergency room visits decreased by 24% and inpatient admission levels decreased by 10% in 2020. You can see right here in this figure the major drop in surgeries and inpatient occupancy in the spring of 2020 itself. While it is known that the social determinants of health are connected to the utilization of healthcare services, little work has been done in Canada to connect the social determinants of health to the experience of unmet needs during the pandemic. It is critical to evaluate this association given the noted higher mortality and morbidity COVID-19 rates that have been seen in vulnerable groups. And so in order to contribute towards filling this gap in the literature, these are the three research objectives that I have proposed. The first is to describe the experience of unmet healthcare needs during the pandemic. The second is to evaluate the association between the social determinants of health and unmet needs. I've chosen a variety of social determinants of health, namely age, sex, province, urban, rural status, racial background, immigrant status, household income, as well as education level, marital status, presence of any chronic conditions, dwelling type, and working status. These determinants were chosen based on prior work that has noted how they affected access to healthcare services. The last objective is to describe the specific challenges and barriers that participants felt prevented them from utilizing healthcare services. In order to conduct this analysis, I'll be using data from the Canadian Longitudinal Study on Aging, commonly referred to as the CLSA. The CLSA is a national cohort survey which recruited approximately 50,000 individuals across the 10 provinces between the ages of 45 to 85 in 2011. The survey will collect data on individuals every 3 years until at least 2033. While baseline data collection was completed in 2015, follow-up one was completed in 2018. All the individuals that participated in the baseline data collection and follow-up one represent the core CLSA dataset. In response to COVID-19, a special survey was launched in April of 2020. All individuals who had participated in follow-up one in 2018 and could still be contacted were invited to apply. Of the 42,500 individuals that participated in follow-up one, 28,600 indicated interest and completed the COVID-19 baseline survey, which means that the survey has a response rate of 67%. After completing the baseline COVID-19 survey, Participants were asked to either complete bi-weekly or weekly surveys, depending on if they were completing the survey via phone or telephone. Afterwards, participants were then asked to complete monthly surveys before the final exit survey was administered between September to December of 2020. While I'll be taking information about the social determinants of health across the various time points, from baseline as well as follow-up 1 and the COVID-19 baseline survey, the outcome of my study, the experience of unmet healthcare needs, will all be taken from that final COVID-19 exit survey. In particular, I'll be using 3 questions that have been included in that survey. Oh, and just a side note, on the slide here, I've also written the URL for the CLSA cohort study. The data is widely available for researchers and for free to students. So if you're interested in the data set, please feel free to explore. Moving back to the main focus of today. So these are the 3 questions that were included in the COVID-19 exit survey. Since the beginning of the COVID-19 pandemic, have you experienced any challenges in accessing healthcare? Were there times when you didn't visit a hospital or doctor? And did you experience any barriers to accessing testing for COVID-19? To the 3 main questions, participants could either answer yes, no, don't know / no answer, as well as refuse to answer. Of course, I'm interested in seeing how the odds of indicating yes to these outcomes changed by the various social determinants of health. If participants indicated yes to the 3 main questions, they were also asked the below follow-up questions. What type of challenges did you experience, and what were the reasons that you were unable to visit the hospital or doctor, and what specific barriers did you face in accessing testing for COVID-19? I'll also be looking into those sub-follow-up questions to be able to answer and fulfill that 3rd research objective, which was to describe the types of challenges and barriers that prevented individuals from being able to access healthcare services. So let's move forward. And now discussing the methods, I'll be conducting a secondary data analysis of the CLSA cohort study. The final data set of analysis consists of 23,972 participants, as those were the individuals that completed the COVID-19 exit survey and had relatively complete socio-demographic information. I'll be reporting the prevalence of each of the 3 outcomes broken down by the various social determinants of health. I'll also be reporting the results of the binary logistic regression models that calculated how the odds of indicating yes to all 3 of the outcomes changed after adjusting for all of the other possible variables. Lastly, I'll be reporting the frequency of the various types of challenges and barriers that resulted in unmet needs, stratified by age and region of residence, because as you'll see, those had a major influence on the level of unmet need. This slide here describes the characteristics of CLA participants that participate in follow-up 1, which was completed in 2018, and then the COVID-19 exit survey, which was completed in 2020. This comparison was done in order to assess how the results of the study may differ if all those individuals from follow-up 1 had gone on to complete the COVID-19 exit survey. We can see that the participants are fairly similar across the 2 time points. We do have a slightly higher proportion of adults with higher levels of education and income during the COVID-19 exit survey, but this is something that's kind of consistently seen in cohort studies. In general, the CLSA sample is fairly evenly split between males and females. Participants largely reside in urban areas. The majority are white and are married or living with a partner. An interesting characteristic to note here is that about 8% of the sample said that they had unmet needs prior to the pandemic. This was measured by asking participants in follow-up 1 if during the past 12 months there was ever a time when they felt that they needed healthcare but they didn't receive it. 2 characteristics not shown in this table are work status and chronic disease status. This is because the comparison for those characteristics across the 2 time points was not possible, as they were not measured in similar ways. Overall, 60% of the sample indicated that they had a chronic disease, and 27% of the sample usually worked outside of the home. Moving on to the outcomes. So 25% of the sample indicated that they had experienced challenges in accessing healthcare services. 8% said that there were times when they didn't visit a hospital or doctor while needing to, and 4% said that they had experienced barriers in accessing testing for COVID-19. Of course, this doesn't tell us much about the socio-demographic characteristics and how they're related to these outcomes. And so the next step was to break each of these outcomes down by the various socio-demographic characteristics, which I have done here for the first outcome. We can see right off the bat that those individuals in older age groups seem to be less but likely to report challenges in accessing healthcare. Those from Ontario as well as BC were more likely to report this outcome. Immigrants were also more likely to report challenges in accessing healthcare. With respect to education and household income, we see a relationship that you might not initially expect. Those individuals that were slightly wealthier and had higher education levels were more likely to report challenges in accessing healthcare services. We also see an interesting relationship with respect to chronic disease as well as unmet need. So those individuals with any chronic condition and those that had expressed unmet needs prior to the pandemic were also more likely to report this outcome. Moving on to the second outcome, which was to be not going to the hospital and visiting a doctor while needing to, we see that same relationship with age as older age groups were less likely to report this outcome. We do see a kind of interesting stratification by sex for this outcome, with females being more likely to indicate this outcome. Also, we see another association with region. So now it's individuals from Quebec that are most likely to report this outcome. And immigrant status also continues to have an influence on this outcome, with immigrants being more likely to report not visiting the hospital or doctor. But now we see a relationship with household income, which runs contrary to what we saw in the previous outcome. So now it's individuals who are wealthier being less likely to indicate actually not visiting a hospital or doctor while needing to. And then we do continue to see a relationship with this outcome with chronic disease as well as unmet needs prior to the pandemic, with those that have chronic disease and those that indicated unmet needs prior to the pandemic being more likely to indicate this outcome. With respect to the last outcome, we do continue to see that same relationship with age, with older adults being less likely to indicate barriers to accessing testing for COVID-19. Now it's individuals from Ontario and BC that are most likely to indicate barriers to accessing testing. And we see that same relationship that we saw with the first outcome, with wealthier and more educated individuals more likely to report facing barriers to testing for COVID-19. And while we see a relationship with unmet need and this outcome, we don't see that same relationship with chronic disease for this outcome that we saw in the previous two outcomes, which was if something was present, if they had any chronic condition, then they were more likely to report that outcome, but we don't see that with respect to testing for COVID-19. So now just to discuss the results of the binary logistic regression models. So for this outcome, which was challenges in accessing healthcare, we see that same relation. We see that age, region, immigrant status, chronic disease status, education level, as well as unmet needs prior to the pandemic continue to have a significant relationship with this outcome, even after adjustment for all of the other variables. The direction of the association remains the same, even as we had seen in the prevalence models. So those that are slightly older, belong to older age groups, were less likely to report this outcome. Moving on to the second outcome, which was not visiting a hospital or doctor while needing to, we see that sex, age, region, immigrant status, as well as chronic disease status and unmet needs prior to the pandemic have a role on the odds of this outcome, even after adjusting for all of the other variables. It's individuals from Quebec now that continue to remain the most likely to report this outcome, and older individuals also continue to remain less likely to indicate this outcome. Lastly, for the last outcome, which is barriers to COVID-19 testing, we see that those from Ontario and BC remain more likely to indicate this outcome. Younger adults remain more likely to indicate this outcome, and those with unmet needs prior to the pandemic have a strong association with this outcome as well. So moving forward to talk about the last research objective, which was to describe the types of challenges and barriers that were faced by participants, we can see that the healthcare services that participants had the most difficulty accessing were primary care, followed by diagnostic testing and specialist care. We don't see quite an interesting relationship with age with respect to this outcome. However, there's more to come. And then with respect to region, we see that those that are living in the Atlantic and the prairies had greater difficulties accessing diagnostic testing, while those living in the Atlantic and Ontario and BC had greater difficulties accessing primary care. In regards to the reasons why participants did not visit the hospital or see a doctor, we see that the major reason is that services were redirected to priority groups, followed by fear of COVID-19 contact. We do see an interesting association with age with respect to this outcome. We see that younger age groups were more likely to indicate that services were redirected to priority groups. And so this sheds light on why they may have been more likely to indicate challenges in accessing healthcare services. And then moving on to breaking down this question by region, we see that services redirected we see that fear of COVID-19 contact was of greater concern to those that were living in Ontario and the prairies and other regions. And for the last question, we see that barriers in accessing COVID-19 testing not being eligible was of greater concern to younger age groups than of older age groups. However, the testing location not being known was of greater concern to older age groups than younger age groups. And we see an interesting relationship with region again for this question. We see that not being eligible was of greater concern to those living in the Atlantic and Quebec. However, longer lineups was of greater concern to those that are living in Ontario and the prairies. So interpretation, or what does all this information really mean? So while it may be surprising that younger age groups were more likely to report unmet healthcare needs, this finding is consistent with data from the Canadian Community Health Survey, and similar results have been seen in the COVID-19 pandemic in Europe as well as Asia. While it is difficult to quantify the exact reasons or know the exact reasons behind this pattern, it is clear that services being redirected to priority groups was a primary concern for younger age groups than of older age groups. As healthcare systems went under reorganization during the pandemic, younger adults may have experienced greater disruptions in care. This was found to be true in Ontario, where the lowest decline in primary care visits was seen in adults above the age of 75. Statistics Canada also reported that younger adults were more likely to indicate seeking testing for COVID-19, and so they may be more likely to indicate facing barriers in attaining the service than older adults. Immigrants and individuals with chronic conditions were more likely to report two of the outcomes, and their relationship with unmet needs has been noted in pre-pandemic literature. This finding was expected as these groups have vulnerabilities that may make it more difficult for them to access healthcare services. This study has also noted considerable differences by province. While Quebec residents were the most likely to indicate not visiting a hospital or doctor, Ontario and BC residents were the most likely to indicate facing any challenges in accessing healthcare and barriers to COVID-19 testing. It is reasonable that Ontario and BC residents reported high levels of unmet need, given the high case counts in the province. Higher education levels were associated with an increased odds of indicating challenges in accessing healthcare services, which is also consistent with data from the Canadian Community Health Survey. While participants with higher levels of education were not particularly more likely to indicate facing barriers to COVID-19 testing in our study, research from Statistics Canada has suggested that they are more likely to indicate seeking testing. Household income was not as consistently associated with unmet healthcare needs after adjustment and in the logistic regression models, which has been noted in pre-pandemic data. Our study was able to describe the unmet healthcare needs of nearly 24,000 older adults in Canada during the COVID-19 pandemic. However, we were unable to quantify the exact change of unmet healthcare needs prior to the pandemic and after the pandemic due to the use of different measurements during follow-up 1 and the COVID-19 exit survey. Also, we were unable to utilize objective measurements of healthcare utilization. However, using subjective measurements did give us insight into how participants perceive the availability of care during the pandemic. Lastly, recruitment of the CLSA at baseline excluded institutionalized persons, as well as residents of the 3 territories or First Nation reserves, individuals not able to participate in English and French, as well as those enlisted in the military. And so by excluding those participants, this ultimately kind of limits the generalizability of the results. To conclude, this study was able to examine the prevalence of unmet healthcare needs during the COVID-19 pandemic and their associations with numerous social determinants of health. we found that 25% of participants indicated challenges in accessing healthcare. 8% reported that there were times when they didn't visit a hospital or doctor while needing to, and 4% said that there were time they experienced barriers in accessing testing for COVID-19. These findings suggest that barriers to services and inadequacies in care persist in the Canadian healthcare system, and they continue to have an impact during the COVID-19 pandemic. And this makes it clear that efforts must continue to ensure proper care for Canadians, even in times of crisis. So in terms of acknowledgements, in addition to my supervisor, I'd just like to thank my thesis committee members, Drs. Lauren Griffith and Aaron Jones. So funding for the CLSA COVID-19 study has been provided by a variety of sources, and core data collection is supported by the Canadian Institute for Health Research. So I thank you all for listening.
Thank you, Jayati. Thank you so much for your presentation. It was very interesting. So right now we have our third presenter who will be joining us in a few minutes, but I noticed that we have a question, and maybe Jayati, we can answer the question so we can have, or actually our third presenter is here. So give us just 1 minute until he can properly join us.
Sorry, so should I answer the question now, or?
Maybe we can do it later because we have our third presenter here, Ahmed Bilal.
Yes.
Yes, hi, you're just in time. Can you share your screen now?
Yes, give me 1 moment.
Sure. Perfect. Thank you very much. So right now we're going to see the presentation of Ahmed Bilal from McMaster University. Thank you, Ahmed.
Thank you so much. Can everybody hear me well and see the presentation?
Everything is good.
Excellent. Thank you so much. So my name is Ahmed Bilal. I am presenting on behalf of my colleagues and the COVID-19 Policies and Epidemiology Working Group on the limitations of policymaking using the COVID data, why it matters for policymaking, and how there are limitations to testing and case counts. Oops. Right. So since COVID started, we have noticed many data and surveillance gaps. The reason this is important is that the pandemic-related policies such as social distancing and working from home can actually help decrease infections, but it will also be socially and economically disruptive to people. Social distancing and other pandemic-related policies have helped decrease infections, but they are disruptive, as we said. Policymakers and their advisors rely on case and death numbers for instituting and evaluating policy decisions. We developed the many limitations that exist in the testing and reporting of COVID-19 numbers, which need to be understood in the analysis and interpretation of policies. The methods for this study, we developed a multiple case study on both national and subnational levels. So we included countries and we included states and provinces. We use documentary reviews such as government websites, media articles, and peer-reviewed journals. We have also used key informant interviews to verify information that we have found or to fill in the gaps. We have developed case studies and reports that are completing the comparative analysis that we did. One thing that we have that really worked very well were our weekly group meetings, where we discuss what is happening in each of our jurisdictions. Our team was composed of many members from all over the world, and this helped conduct interviews in many languages in many countries. This is an example of the countries that we included in our studies. As you can see, we are relying on these numbers to be accurate in order to make decisions about what policies work and what policies do not work, and what countries we should start depending on to see what is working and what's not working. We identified many barriers to testing and reporting for COVID-19. there is a level of the healthcare recipient, and there are some barriers to testing and reporting on the sample collection and processing level, and there's on the surveillance and reporting levels as well. On the healthcare recipient, there are levels of where we can find barriers to testing as well. Testing starts with individuals getting tested, the first step. There may be times when it's predetermined who gets tested and when, such as, for example, healthcare workers getting tested prior to starting working in a long-term care facility, or travelers returning from overseas. However, most individuals are tested in the community, where a number of steps predictate individual decision to seeking out testing. First of all, availability of education and decision supports is needed for people to understand that there is actually a pandemic going on. What that means is how it might impact them and how and where to get tested if available, and why getting tested is important for them and their loved ones. This relies on accurate and timely information. The testing criteria have changed throughout the pandemic. Some places required referrals to testing and some didn't. Referrals adds burden to people who require testing. Some countries only allow symptomatic people to get tested, and then it changed to people traveling in and out of a country. Once people decided to get tested, there is a lot of decision-making that is involved. For example, their health status and their health literacy, and the trade-offs between the pros and the cons of knowing the results. If you are infected, you may be able to isolate to protect your loved ones, but you also might have to be not allowed to go to work, and your income will decrease. In some countries, testing is not free, even if you are symptomatic. Even if you came in contact with an infected individual, you still have to pay to get tested. In some places, you have to go to a private lab to avoid long waiting times and crowded waiting areas, which is more expensive as well. In other places, if you need a certifiable certificate for travel, you need to pay extra, sometimes much extra. And this added to the out-of-pocket expenses for individuals. We often think of testing as one entity on its own, but it's actually several, 1 to 3 different steps. You need to have the testing site, so there has to be availability and accessibility of testing sites. And testing sites might include already available clinics, hospitals, or community sites, or assessment centers may be created for the purpose of testing on its own. Having separate assessment centers can ease conflicting burdens on already overwhelmed health system, but it can allow for efficiency in the process of testing and in keeping potentially infectious individuals separate from those who are seen for other things. You need also people and you need supplies for testing. Specimen collection and management sometimes require transportation to the laboratories where these tests are processed. So we need laboratory capacity, you need people, you need trained personnel, and plenty of supplies. Once you get people screened and you get to the test results, you need to be able to do something with that information. So if each site has its own data management system, it's going to be really difficult to put all of that together to inform policy. So we need coordination of information technology systems to form a robust surveillance system and a notification system. So a national data management system is required, but in order for that to work, we need the local sites to inform the national data management system, and then the national data management system would inform researchers, policymakers, and the public. This is the part of knowledge translation. We need transparency and accountability in this process that have to be there has to be a political will in order for it to work. We've seen determinantal effects of lack of political will in places such as the United States and Brazil, where the president downplayed COVID for a long time, and that affected the policies that are implemented in these places. we need to be able to have good communication between researchers, and we need to have trust between government and the public. Policymakers and the public need to have trust so that people need to know if they have to get tested and what's happening and what the risk might be if they go tested in specific places. As part of our group, we developed this website, which has a summary of what we have achieved so far, and we share the information that we're finding. We've developed also a database for policy relevant international factors, and we have also case study reports that are published in many places. So the takeaways for today: there are many barriers to testing unreported for COVID-19 cases, which can lead to undercounting, improper interpretation for policy decisions, and loss of trust in governments. The listed barriers do not even include the COVID-19 contact tracing, case management, or defining and counting of COVID-19 related deaths, but all play a role in the spread of COVID-19. Understanding the links between testing, data, and action underlines the country response to the pandemic. And understanding contextual factors in testing is important for cross-jurisdictions comparisons of policy decisions and their effects. This is where our project is registered, and these are our contact information. And thank you so much for your attention.
Thank you so much, Ahmed. So right now we will start with Dr. Seow, our discussant. So we have a couple of questions. Dr. Seow.
Oh, thank you so much. Well, welcome everyone, and nice to meet you all virtually. I know everyone doesn't have their camera on, but I know there's a person behind there. If you want, you can wave for a second and turn your camera off. But I do want to we have about 45 minutes, so I do want to be able to make this as a lively discussion and as interactive as possible. So as we're chatting, please continue to put questions in the chat box, and I will try, and Tatiana will help me to manage that too. But I think perhaps the best way to do this is just to go in order, and maybe we'll do we'll put someone in the hot seat in order, and if that's okay with folks, and we'll spend maybe 10 minutes and we'll just try to go a little bit deeper for each presentation, and then we can keep is that okay? All right. So Joelle, great presentation. Thank you so much. I had some questions. Okay. You did a rapid review.
Mhm.
And I wondered what your thoughts were of the different other kinds of reviews that are out there, like a scoping review, systematic review. Like, what is the difference, and why did you choose the rapid review?
Yeah, so thank you for your question. As I was starting out my research, my main concern was, what kind of review do I want to do and why? So I did a lot of different research into the different types of reviews and tried to find what would be the best fit for me. So at the time I was doing my MBA and MPH. So I was busy with a full course load, and I also had a placement. As part of one of my courses, I actually did this research project, and we only had one semester to really complete it. So the best fit for me was actually the rapid review, because it allowed me to only have one screener to screen all the articles rather than two or more. That was one of the examples, but also it allowed me to perform the entire review within the 4 months of my course. And that was one of the greatest benefits. A literature review, the reason why I did not do that is because it was just more structured, and because COVID-19 is so recent and there's not much research out there, it was difficult to be flexible in my research and in for the literature review, because I had to play around with the keywords, and I couldn't really define them at the beginning of my research, because I would go through all the databases and realize, well, I didn't find enough here, and then have to redo my search all over again. So that's the reason why I ended up choosing the rapid review.
And there are obviously strengths to doing that. So compared, like, what is the intent? Like, what is the purpose of a rapid review compared to, and maybe, and if, you know, I'm not trying to put you on, if you're not sure, that's okay. I just wanted to just flesh out a little bit, because there are obviously benefits to doing what you've done. And so if you're able to just compare what were some of the pros of doing it this way versus, say, a scoping, like the intent, what is the purpose of a rapid review and why would you do it?
Yeah, so I forget the fine details at this point, but the main details were that for a rapid review, I could do it in a shorter timeline, and I could also be flexible with which databases I include, and with my search terms, really. So instead of having like a defined set of terms, I was able to be a bit more flexible with
Sure.
what I ended up including. The timeline was one thing.
Okay.
I think there was something to do with COVID-19, because it was so recent that it was difficult to get articles when I started my research. So I had to be a bit more flexible in terms of that.
Sounds good. And okay, so you have done this review, you had your 5 sort of take home themes, which I remember. Do you feel like, what are some of the things that, the data that you wish you could have found and that the articles could have spoken to, but you were not able to find?
Yeah, so the main one was cost. So I really wanted this paper to be emphasized on cost and the cost effectiveness of social technologies, in terms of, you know, implementing the social technology improved older adults' mental health and well-being compared to them not using these social technologies, or like comparing from different long-term care homes that did not implement social technology use. And I could not find anything at all on cost. So that's one of the reasons why I actually had to redo my search, is because cost for me was number one, and there was barely maybe 1 or 2 articles within thousands that had included COVID-19, mental health, older adults, and cost. So, and the use of social technologies. So that was the one that I hope for future research, we can consider cost, and that way we can inform policymakers to consider, you know, maybe including social technologies in our long-term care home, and including the increasing staff in order to support these processes is cost effective in terms of older adults' mental health and well-being.
Yeah, it's such a hot topic that, like, the topic of your review is so clear. And yet, I wonder if after you have done your review and you have, you've scratched 114 and you came up with your 11 and you have your implications, like, as you're thinking about what you would tell, the minister of long-term care, the one who's responsible for long-term care, I mean, what do you think that they are? I guess, maybe part of the question is, what would you want them to take away of all that you learned, to the best of your knowledge, your evidence? What would you want them to learn? And what do you think that they're going to say?
I would want them to learn that in order for long-term care residents and older adults to stay healthier, to stay positive, and to stick to the COVID-19 guidelines and restrictions, it's important that they maintain social connectedness, even through the restrictions of having to isolate. And at the same time, stay healthy and stay connected with their activities that they love and with the people that they love, in order to abide by these restrictions, because it's difficult when they're isolated and they're lonely and then they don't have any more motivation. And we're in 2 years into the pandemic, so we're not just asking them to isolate for a couple weeks. So I would urge them to think of how important social technologies are in their lives and how they're the sole thing to keep them together during this difficult time. And it will also benefit our hospital, our healthcare system, families, because by them staying isolated but having these social technologies, they're not contracting, hopefully not contracting the disease because they won't be in contact with others. And that will result in them not having to use the healthcare system and go into the hospital and need a ventilator. So this is not just one tiny aspect. It really affects everything, and it affects how our healthcare system operates.
Perfect. I have two more and then I'm going to change the Hitachi, but I'm going to, Tatiana, was there a question for Joelle in the chat? I believe that there was.
Yeah, I think I responded.
Yes, I was just like, if you can, the question was actually, hold on a second, where was it? Great presentation, Joelle. I'm interested in knowing more about the types of technologies, and if you think the current technology social media options need to be improved for the long-term care population. You can like sum your answer.
Yeah, so I basically summarized that the main social technologies that were used were video-based conferencing, such as Zoom, there was FaceTime and Skype. Those were the main three. However, any type of video conferencing or any type of social technology was included. And I responded that I do think that it could be improved in some aspects. I mean, myself and my parents are sometimes struggling getting onto their Zoom call, right? So I'm sure that by making the settings a bit easier so that it's easier for them to access, or even having a voice recognition to start up a call and say, here, hey, I want to call so-and-so. That would really improve their ability to autonomously use these platforms, because it can be difficult to start a meeting, get into a meeting. Even I'm having difficulties sometimes. So yeah, I think little accessibility additions like that would really go a long way for this population.
Okay, and do you think your results, last question before I move on, is from what you learned, how strongly do you feel that your results could be applied to populations outside of long-term care?
I think they could really be applied to every population, because it's not just older adults that have to be careful, although they are the most vulnerable population. It also could be applied to people of all ages, or especially younger children who at a time they weren't able to go to school and they were really struggling, right? So I think that this would be a really great implementation for children and yeah, people of all ages.
Thank you. Okay, don't go away there. We may have time for more, but I'm going to move to Jayati. Thank you. And you talked about the social determinants of health on unmet needs of patients from the CLSA, the Canadian Longitudinal Study of Aging, a huge data set. Okay. I'm curious to know, what was your hypothesis going in, and did your results reflect your hypothesis?
So they reflected it sometimes and then not other times, I'd say. I think my initial hypothesis was that, especially with income and education, to see that kind of individuals with lower levels of income and lower levels of education were more likely to report all three of the outcomes. And we saw that that wasn't really true, and household income wasn't really associated with any of the three outcomes after being adjusted for. So that was one thing that was kind of surprising to me. But then when I kind of dived further into the literature, I've seen that this has been something that's been found consistently across studies. So that was my initial hypothesis, but then I've come to see that that's not really true. And then one thing that I did kind of expect to see was that immigrants would have higher levels of unmet need than non-immigrants, because it's been shown in the literature that due to language difficulties, due to transportation difficulties, or income difficulties, they do typically have higher levels of unmet need. So I think that was a hypothesis that did kind of come true with respect to the two outcomes, challenges in accessing healthcare and not visiting a hospital or doctor.
Okay, so the immigrant hypothesis that they would be more likely to have unmet needs you found to be true, but higher income, higher education, you thought they would have less unmet need, but they actually reported more.
Yes.
Why do you think that is?
I think they have a greater expectation of care. So then when that level of care is not met, they may be more likely to report unmet needs. That's
Okay.
what's kind of been suggested. It's not necessarily, it's difficult to say exactly why, because, the qualitative work isn't really there to explore, okay, these people they have a certain level of expectation of care. So this is all, of course, just kind of quantitative assessment and thinking about what may be the factors behind this. Beyond the fact that they might have a higher level of care, expectation of care, I think they also were more likely to indicate seeking services. So that was one of the reasons why I thought they might be more likely to, one of the reasons that I think contributes to the fact that they were more likely to indicate barriers to COVID-19 testing. So that kind of, I think, also justified the results that we saw.
Okay, what about response bias? How do you feel like the sample size that responded, and how do you feel like what were the pluses and minuses of your response rate?
So that's definitely something that I think is kind of part of cohort studies, because it always people that are wealthier and more educated tend to be the ones that tend to participate in the cohort studies. And so that for sure is, I'm sure, influencing the results that I was able to see. Also, the CLSA sample is about, the COVID-19 sample is about 97% white. So given that the population of Canada is about 80% white, that's a pretty big difference in terms of racial background in the CLSA sample, and then in what is actually in the Canadian population. So I suspect that that has been a response bias as well, and why we may not have seen differences according to racial background, but there may be differences in racial background. It's just that the sample size is so of racialized participants in the CLSA is so small that we weren't able to detect any significant differences.
And do you think that, was there an incentive to complete the survey? I'm just curious. Probably, right? Or no?
No, there's no incentive.
Okay, so do you think that maybe, I know you did the comparison, but people who are more vulnerable, who are holding 3 jobs, I'm just making stuff up, maybe they're less likely to complete the survey, and thus you're missing them in their data, potentially. I think you sort of hinted at that, but that's just another piece.
Yes, I think that for sure is true. And those that are in more vulnerable situations may be less likely to continue to complete the survey. While I didn't do this analysis, it has been done in CLS, where the baseline data collection, which was completed in 2015, was compared to the follow-up data collection from 2018. So they were able to see that same sort of relationship, the same thing that you might expect, where individuals with lower levels of income were more likely to drop out. Females were also more likely to drop out of the survey. So that is something that we has been seen in this cohort study.
Because they have undue burden to do everything, keep it all together. Okay, Tatiana, did we have any questions for Jayati in the chat? I thought so too. Yeah.
Yes. So the first question is how primary care is defined in your study?
So primary care was defined as access to a physician, nurse. Sorry, 1 second. I think I wrote that response in the, yes. It was access to a family physician, as well as a nurse practitioner and other primary care team members. I know that the follow-up question asked about home care specifically and why that was excluded for, but I just have to say it wasn't excluded for, it just wasn't explicitly included. So participants were given the option of indicating primary care, and these were the options that were just in the bracket for them to indicate family physician and nurse practitioner and other primary team care members. So it's not like the home care was excluded entirely, it just wasn't explicitly included in the CLSA question. And while it's unfortunate that it wasn't explicitly included, the survey was kind of made in September and December of 2020. So it's difficult to know exactly what to add at those time points because, you know, the pandemic was going on at that time and our information and how much we know about the pandemic was still evolving. So that's my answer to that question. Thank you.
Great.
We have another question also. It says, access to family physician, nurse practitioner was still a risk factor of exposure, right?
So I was a little confused about that question. A risk factor for the exposure to COVID-19 or?
I think what they mean is, did you include access to primary care as a covariate in your regression models?
No, I did not include that as a covariate in the regression model. That's because we suspected that it would be highly correlated with unmet needs prior to the pandemic. And so we just wanted to keep this model somewhat parsimonious as we could. And so we did not include that in the final model.
And this is a very minor thing, but one of the pictures graph said, so their past, if they replied that they had an unmet need in a prior survey, right? They were 70% more likely to have an unmet need in this survey, right? Is that what I understood from that? Yeah, I know there's 3 outcomes. So.
Sorry, which graph?
It's okay. It's okay. But I mean, is that what you found? Like you did control for, did they have a prior unmet need compared to this future unmet need, right?
Yes, we did control for that in the and all three of the outcomes we controlled for that, and we saw I mean it was strongly related to all 3 of the outcomes. The odds ratios are all above 1. The odds ratios for the first 2 outcomes are in the range of 2. Mm-hmm. So they're all pretty strongly associated.
And if I heard you right, you said in the prior survey it was like 8% had an unmet need, and now in this survey it's 25%. Yes, something like that.
So in the prior survey in follow-up 1, the question was worded a little bit differently. It was worded by asking if participants in the past 12 months had if there was ever a time when they felt that they needed healthcare but they didn't receive it. So that question, while only 8% of the respondents said yes to that, 25% said that they had experienced challenges in accessing healthcare during the pandemic.
Okay, perfect. Okay, and I'll ask you the same question I asked Joelle before I move on is, if you had a policymaker in front of you now, what would you say as your take-home message to them for the policy relevance piece?
I'd say that this is a concern for particularly, I think what we've seen is that there's a persistent group that's having difficulties in accessing healthcare, given the fact that those with individuals with chronic conditions, as well as those that reported unmet needs, have consistently kind of been selecting the fact that they have unmet needs, as well as the fact that they were unable to access healthcare services during the COVID-19 pandemic. So I think that's a cause for concern, and that we need to look more into this population and see how best we can accommodate them. I also feel that we need to perhaps take a greater look into access to healthcare services for younger age groups and how that was interrupted during the pandemic, and pay greater attention to that as well.
Thank you. I see in my note to myself, there were 2 other questions for you specifically, Jatu. So I'm going to turn over to Tatiana.
Yes, I'm going to read the 2 questions. Unmet needs from the system, and basic question, how unmet needs is defined? Sorry if I have missed it, it's already explained.
So in general, unmet needs is defined as a lack of accessibility or availability of care, as well as I'll just clarify. This is a subjective measurement of the healthcare system, where individuals themselves are indicating how they perceive the quality, as well as the acceptability, as well as the availability of care. So it's an individual's perception of the care that they're receiving or that they're not receiving. In my study, unmet healthcare needs has been measured using 3 outcomes, which is the experience of not being able to access, experiencing challenges at accessing healthcare services. It's also not being able to visit a hospital or doctor while needing to, and experiencing barriers to COVID-19 testing.
Was there another one, Tatiana?
No, I read it too.
Oh, okay, perfect. Okay, thank you. Don't worry, I will come back with the wrap up. Okay, Ahmed, thank you for your presentation. I have to apologize because I had to do something at my door just as you were explaining the people that you had connected with, like all the countries and people and that you were able to connect with. So can you just remind me, just help me understand, who did you survey them? Did you email them? Did you interview them? Like, who were the people that you spoke to get your data?
All right. So our project started as an idea for another project. So we had an idea of interviewing people and getting government to know what policies work. So does social distancing work? Does it not work? So we surveyed the numbers. We saw the numbers from countries, and we started to do interviewed with people involved in it. So we interviewed physicians, we interviewed hospital managers, we interviewed regular people who received the service of testing in many different countries. We have 50 countries in our database, and we have a team of like 50 members at least, with each member responsible for one country. And from what we heard from the interviews is that there is a big problem in reporting of cases and death in many countries. So we shifted to this specific idea of why there is this discrepancy in numbers in many jurisdictions, where it's countries or states, between the reporting and testing. Why do people not want to go get tested? Why is the reporting numbers different? So we interviewed plenty of people. We tried to reach policymakers, and we succeeded in many jurisdictions. I, for example, interviewed one of the health minister assistants in Egypt. So this was actually why we decided to go this way on about the topic to be about testing and reporting, and why there are some discrepancies there.
Okay, so I noticed that you did a very nice job of laying out all the many different steps in the reporting and all the different things that could go wrong. And in some ways, it's like an epidemiology class of like, when you measure something, it's not so straightforward. Here are all the things you have to consider so that your results are comparable or not. And I also noticed that when you were giving examples of differences, you didn't name countries. Was that intentional? As in you were trying to protect, not make people look bad, or what was the thought behind that?
Well, it's because we have plenty of countries, and some of them are very specific to countries, and some of them are general. So for example, there is, I named Brazil and the United States because this was a very apparent example of political will, where the presidents did not want to create panic among the population, so they spread misinformation instead of panic, which eventually created more panic among the people. I can speak for example, in Egypt, in June, the Minister of Health announced that we do not have any Delta variant in the country. And then in early September, she said, well, we actually had Delta variant 2 months ago, but I didn't want to create any panic. So this actually was a big gap in information and transparency, and this created less trust in the government. So to answer back to your question about why I didn't specify countries, it's not intentional. It's just that there were many reasons, and some of them were specific to countries and some of them were generalizable. So for example, the creating of new sites, this is a barrier that was prevalent in almost all countries. So many people said that we need more sites for testing. That's early in the pandemic. We need more sites to be created specifically for that, to avoid crowdedness and to avoid people getting actually infected when they are trying just to get tested. So this is something that was almost everywhere.
So when you go to write up these results or to report them, do you think you and your co-investigators, what kind of discussion are you going to have about identifying countries who do X, Y, and Z? Like, do you think, I don't know if you have been presenting it at different places, but is there some sensitivities there? And what do you think is the balance to be struck? Because some of these people talk to you, right, to try to, I don't know, confidentially or to give, to participate. But if they don't want to look bad necessarily.
Exactly. Yes. So this is actually one of the barriers that we identified to getting information. People do not want to conduct interviews in some countries, specifically in the Middle East region, because they are afraid of prosecution by their governments, because the government doesn't want physicians or the public to talk to the media, specifically media from the Western world. So we are from McMaster. So they are afraid that if they talk to the Western media, they would look bad. So they actually have some restrictions on physicians talking to media, and they got persecuted. And in some countries, they actually went to jail because they talked and displayed numbers and displayed that actually the numbers that we are seeing in the hospitals is much bigger than the numbers that the government is announcing. So for example, there was one interview that a colleague conducted in a certain country that should not be named. And the physician that was talking to them said that in my hospital alone, I saw in that week at least 300 cases of COVID. And the country announced that in that week, overall, all over the country, they had 270 cases. So in one hospital, it was much more than the country announced. So this is among the reasons people do not disclose information. And this is one of the reasons why people rejected participating in our project as a whole.
Okay, so Ahmed, you shouldn't be surprised. I'm going to ask you if, first of all, who is the policymaker that you would want to be talking to? Who is the best policymaker for the results of your study?
Well, typically a minister of health, someone who has the authority to conduct, to implement policies, to implement new ideas, to talk to the public, first of all, and have some trust between them and the public. So if a minister of health doesn't have any, if there's no trust between the public and the Ministry of Health in a certain country, I wouldn't want to talk to them. I would go to a lower level where people have trust in them.
Okay.
So
and what would you say? Yeah, where there's trust. And what would you want them to know? Like, what is your take-home message from what you've done?
I would say that transparency and trust is very important if you want to actually solve the problem in your country. So either if you want to do it through mitigation or through containment or whatever, you need trust to build trust with the public so that they know that these tests are credible, these results are credible, these numbers are credible. So if you say that you have X number of cases in a certain city and the actual number is X by 20, for example, people would act upon this. People would go into public spaces upon your information. And if you do not give accurate information, people would act upon the inaccurate information, and this would actually make the problem worse. It will create more panic. So if you're trying to lessen the number, try to make the problem look better for political reasons to not create panic. This will eventually create more panic in very little time, more than you think.
Okay. So we're in our last, 15 minutes or so. I'm going to invite all the people who are participating, particularly the graduate students who are cheering on their friends, but also learning. If you have questions, final questions for any of our three presenters, now is a great time to put them in the chat as I sort of do one more round for everyone. Okay. I invite you to do that if you're interested. Okay. So I'm going to ask this question to all three of you, but you're starting. Oh, okay. Go. Wonderful. Tamika has, do you want to ask it, Tatiana?
Sure. I had another question for Ahmed too, but I'll do that afterwards. What countries have the most effective and ineffective policies related to COVID? And what were the lessons that could be learned?
So there are plenty of policies when it comes to COVID. There is the working from home. There is social distancing in closed places. There are limiting the number of people who can enter a certain closed area. So many countries have implemented these kind of policies, and the countries that can actually enforce these policies are the countries that we saw good results from. So there are countries that say, yeah, we have these kinds of policies like the United States, but they do not enforce them. There are many places that did not enforce these kinds of policies of limiting the numbers of people entering and actually enforcing mask wearing in certain places. We did not see good results, although they say they implement the policies, but they did not enforce them. So on the government level, they say, yeah, we have policies in place, but on the local level, they were not enforced. So we didn't see good results. In some jurisdictions, like for example, in Canada, after the first wave, we have seen some numbers improving, the case number going down, and the death toll going down. So that was because people actually implement the policies in certain areas in Canada, in certain provinces. The policies were actually implemented and enforced. So we have seen good numbers there. What are the lessons that could be learned? As I said, the trust between the public and the government is really important for people to know that the information that they're getting is accurate. Enforcing the policies is important, just as applying them on paper, in theory. Enforcing the policies have to be having a strong will, a political will to support it, and also trust between the public and the local and national governments in order to be implemented.
We have another question, and I think this is for Ahmed, and we have another one for Joel. Optimistically, let's hope the COVID-19 pandemic ends soon. Do you think your study results are still useful? How?
Yeah, I think that, well, we all hope that ends soon, of course. I think the results could be useful, if not for the next pandemic. Currently, we do not have a fifth wave, hopefully, but in some countries, the vaccination rates are not going as high as it should. So in these countries, the results that we have now of what policies work and what policies do not work should be useful to them, as long as their vaccination rates do not go up. There are many countries in certain areas in Africa and the Middle East region and in Asia, the vaccination rates are not going as high as possible due to different reasons, economically and politically. But these results could be useful to them in order for them to at least try to mitigate the implications of COVID-19. For example, in some countries, they believed that having school return in person would increase the numbers of COVID-19. So they postponed school for weeks or even months in some areas, because they thought that since the vaccination rates are not going high enough, they should not open such places where people would interact in person. And this actually worked in some places.
We have a question for Joel. It says, do you think that ownership would impact implementing social technologies in LTCs, like difference between public LTC homes and privately owned homes?
Yeah, I think that, well, the difference would primarily be in funding, so how they get their resources and their money, as well as, I guess, what they believe in as a long-term care home. If they're privately owned, then maybe they have different beliefs and they different than the publicly owned ones. So I think that for policymakers, they need to ensure that either privately or publicly owned, that they are both abiding by the guidelines and that they're both implementing social technologies. But yeah, I think that would definitely be a jurisdictional concern, whether or not it's privately or publicly owned.
And Tatiana, I thought you had a question too. Go ahead.
Sorry, I had a question for Ahmed. So not like depending on the country, you have federal countries like Canada, where each province has their own policy making decision person, and you have other countries which is the national authority, say the Ministry of Public Health. So did you approach the decision maker depending on these characteristics of the country, or did you just go to one like the national level? Sorry, I found that was interesting because that makes a big difference on who's reporting and
absolutely, yeah. Absolutely, no. On countries that have the health making decision is on more local level, we approach it this level. So in countries like Canada, we try to examine how it's going in each province separately, not on the national level. So we have a case study for Ontario, one for Quebec, one for British Columbia, one for Newfoundland and Labrador, one for Alberta, and I think there is another one for Saskatchewan. So we have case studies for each province, and same goes with the United States. We have at least 10 states that have separate case studies where we try to examine how case reporting is going and how the social and physical distancing policies are being implemented. So, and there are other places like, for example, India, and there is Brazil and the United Arab Emirates, where there are several sub-national level policymakers that are in charge of health systems decisions. And there in these places, we try to examine every, let's say, province on its own as a separate case study.
Excellent. Okay, well, my final question for you, and I'll start with Jayati, is, okay, you've all did great presentations, congratulations, presented your research, but you've done it as researchers and in some ways advocates for whoever you asked the question on behalf in the public's interest. I want you to put yourself, and I asked you all, what would your take-home message be? Oh, I think we ran out of time for, I meant to say that, but if you did, okay. And so I want you to put yourself in the decision makers' shoes, the policymakers. I'm curious, either what are the considerations that are now in your mind that may or may not, that have to be weighed against this evidence, or how would you respond to your sort of take-home message? Not respond, but what would some of the counter arguments be? I always think it's important to think in their shoes, because you want to present evidence, or to, like a debate, you want to, or in court, you want to prepare to counter what they're going to say. So what, Jadi, you talked about the social determinants of health and how immigrants, maybe, you have a bit of a bias with income, but you have a suspicion that they need, specific policies for them. So if you, as a policymaker now, why haven't they done that? What is there in their mind that's preventing them from doing so?
So I think if I were to act as a policymaker, part of my opposition maybe towards making certain changes would be due to the limitations in the data set. So for example, I've talked about how, unfortunately, this is only a cross-sectional study really, and I was unable to explore how the experience of unmet needs really changed during the pandemic. So I don't have a measure of before and after the pandemic. There's no, unmet needs increased during the pandemic. It's just, this is the experience of individuals during the pandemic. And so as a policymaker, I would kind of be reluctant to see the COVID-19 pandemic maybe as having such a big impact on people's unmet healthcare needs. Also, we know that immigrants and those with chronic conditions have been experiencing persistent difficulties with accessing healthcare services. So this isn't something that's new or possibly worsened any outcomes, but so that's why I think I would be reluctant as a policymaker maybe towards making some of these changes, because I would think that these may be factors that the COVID-19 pandemic hasn't really deepened, but have always kind of persisted. So I think that's
okay.
One barrier, yeah.
And Joelle, same question. So you talked about the need to increase access and use of these ICTs in long-term care homes. Why haven't they done that? What else are they thinking about that's preventing them from doing so?
I think there are a few things. So one of the main things is that there's no cost effectiveness analysis. So they really aren't sure how much money they're going to save by implementing this. Also, there's no quantitative baseline comparison, so no measure of quality of life, and no quantitative measure of how this will decrease mortality or even COVID-19 cases or ventilator use. So I think those measures are really important, and that's really what is going to change their mind.
Okay, and Ahmed, what would you, if you had a chance, what would you say to them? What would the take-home message be? And then put yourself in the other shoes.
So the take-home message would be increase the testing sites, increase the efficiency of the process of testing and reporting so that we know what is really happening on the ground, create more trust between the government and the public, create more trust in the health system and the physicians that are dealing with that. And as a policymaker, I would say, well, that's all good, but we do not have the money to do that. We do not have the money to test everybody for free. We do not have the money to create more sites. People who want to travel can pay an extra $100 if they are paying $1,000 for the ticket. They can pay an extra $100 for the certificate of the COVID test, and we can make money to build more sites with that. So give me the money, and I'll do all that for you.
Thank you. Y'all did a great job. I know we're at time, so I want to turn over to Tatiana to say the final thank you, but good job, all of you.
Thank you very much. Alex?
Thanks, everyone. What a fantastic set of presentations. We want to thank all of our presenters for sharing their work and our discussant, Dr. Seow, for your insights in facilitating the session. We will be having our final set of presentations for the health economics stream on November 16th at 11 a.m. Registration for that session is still open. And to conclude our conference, we will have our panel session called Rebuilding the Plane While We Fly, Innovation Within Existing Policy Structures on November 23rd at 1 p.m. And registration is still open for that as well. If you have any questions, please reach out to us at nfhp@mcmaster.ca. And as a reminder, the 30th LaBelle lecture is happening tomorrow, so November 10th from 3 to 5 p.m. This year's speaker is Dr. Jay Shaw from the Dalla Lana School of Public Health at the University of Toronto, and his lecture is on innovation, titled Will Innovation Save Healthcare? Issues and Opportunities for Healthcare as a Public Good. For more information about that and to register, please visit the CHEPA website. Thank you all and see you next week.
Thank you. Thank you, everybody.
Bye, everyone.